Hello, this is Ruth Parnell. I'm going to be talking to you about the do's and do nots of documentation. Three primary reasons for documentation. One is that it tells the story of the patient. That is, you're actively writing the patient's medical biography. The second reason is for reimbursement. Oftentimes, reimbursement is based on proper, thorough, and complete documentation. And the old adage, if you do not document, it wasn't done, comes into play very well. The third is the legal implications, and these can be scary. The ignorance of standards and practices in your profession no longer serves as a viable defense when you are defending your documentation on the stands. And careful documentation of what occurred and what actions were taken can be important sometimes months and years later after the incident. An individual has the right to be able to file any kind of legal thing years after an incident occurs. I believe it's a statute of 2 years. So a lot of times, if you don't document, you can't rely on your memory all the time to determine. The medical field has several different kinds of communication styles that they learn. A physician is trained to be very brief and concise when they're documenting. They use bullet points a lot of times, and they are there to deliver clear recommendations and diagnoses. A lot of times you have to muddle through just the bullet points to figure out what the doctor is actually going for. Nurses are trained to give detailed descriptions of patients' conditions, symptoms, and treatments, and not provide a diagnosis or medical opinions. They typically write in a narrative form and are to be as thorough as possible without including opinions or their thoughts on what the patient is going through. Social workers, on the other hand, are trained to document the holistic view of a patient, and that includes their mental, emotional, and psychosocial well-being. They are typically document the touchy-feely component of healthcare. But when you look at these three types of documentation, there's a lot of opportunity for misunderstanding and missing the point that somebody's trying to make because of their methods in communication. So we have to be careful in how we document so we're very clear to eliminate any potential. There's the general documentation requirements for medical certified home health. These are the general requirements that are required by Medicare and Medi-Cal for documentation of what needs to be in the chart. Now, this isn't a list of what is expected to be documented on a per visit method. This is what has to be considered. It has to be in each medical chart in its entirety. So the first thing is the demographic information of the patient, and that includes their age, their sex, their address, phone number, what their date of birth is, what their primary language is. Sometimes it's what their religious preferences are, the contact people in case of emergency, and any legal representatives or that they have listed. This should always be the first piece of information that is accumulated in a chart. The medical history should always include the diagnosis, the medications and treatments and procedures that they've had in the past. This is a medical history, so it's not just what's being done for this patient at the time, but the history of what their medical condition is. Any informed consents and advance directives should be clearly documented in the chart. If there is a advance directive or a post in the state of California can be an advance directive. It needs to be in the chart. Advance directives and posts are not mandated. They're not required in a chart. But if they are not in there and the patient does not want to have an advance directive or have a pulse, then that needs to be documented in the chart very clearly, that they are a full code patient. Informed consents are very important, and they should always be on a different form, a separate sheet of paper. The informed consent could be just the consent to treat, but that needs to be very evident and in the chart, very easily accessible. And documentation should reflect collaboration with all the disciplines involved in the patient care. and it needs to be presented in an interdisciplinary manner. So your plan of care needs to be as interdisciplinary as possible, and that includes your physician, your social workers, if there are any clergy individuals that might be involved in the care. Of course, the nurses and the home health aides. Anybody needs to be reflected in the discipline and in the involvement of their care. The need for home health needs to be justified to provide the care, the treatment, and the services needed to meet the patient's specific goals. This is very important. The documentation does need to show that the care that they're provided is required to be reimbursed within the Medicare, Medi-Cal programs. Those that are privately paid or paid in other manners don't necessarily need to have the same level of care, but I would, just as a standard of practice, make sure that the care is justified. Documentation should support the patient's current condition and listed diagnoses. So your documentation needs to support that what you are doing in treating for this patient is articulated in their current condition and their list of diagnoses. If there is something that you're treating that is not listed in the diagnosis, then it needs to be placed in the diagnosis list. So an individual comes in, as an example, let's say they came in, you're treating them for a stroke, but they end up with pneumonia. Pneumonia has not been previously listed, so they end up with a diagnosis of pneumonia to treat them with the antibiotics. That needs to be included in the diagnosis. Once that treatment's done, the pneumonia has been resolved, then that can be a resolved diagnosis, but that maintains a listing in the diagnosis, however, as resolved. Any care needed on an intermittent basis should be supported in the documentation. That is what I just explained about the pneumonia or something like that. Let's say a patient requires some therapy for a period of time where they had not needed that in the earlier times. That would include there as well. Documentation should reflect the reasons for homebound status. This is very important to be reimbursed for home health in the Medicare system. You do need to document that homebound status. And a patient's progress towards the goals outlined in the plan of care should be evaluated and documented on a routine basis. This is very important to show that the patient is either meeting the goals or goals need to be changed in the plan of care to reflect what they're doing at the time. In the past, there was a term used for home health documentation that indicated that it is you document negative documentation, which means that you're documenting what the patient cannot do as opposed to what they have accomplished. So an individual that is needing assistance with ambulation, they're able to ambulate a little bit now, but they still require assistance. So in home health, your documentation would be that you still require assistance with ambulation. You would not say that they were improving on their ambulation and can walk X amount of steps. Any revisions to the plan of care should be supported with documentation on progress towards those goals. So any changes that you make in the plan of correction or the plan of care should be supported in your documentation always. And that plan of care should be adjusted and updated with the dates reflecting those adjustments and those updates. Documentation should reflect any communications with physicians regarding any changes in the patient's condition. It's really important to make sure any kind of documentation when it comes to a changing condition is met. And that documentation isn't just the communication with the physician, but what you've done about that change of condition to make sure it's on the plan of care, that it's supported throughout the chart. Interdisciplinary communications reflecting a change in condition should be documented. So any interdisciplinary communications, whether it be between nursing staff or with outside sources, let's say therapy or clergy or social services, those need to be documented in the chart. All communications with patient, physician, interdisciplinary team, organizations involved in care, and organizations receiving are documented. So if a patient is discharged to the hospital, you're documenting on a transfer record. It's not stating that all this documentation has to be in a nurse's note. It just needs to be in the chart. And that chart, like I said before, is the patient's medical biography. So it should be easily read from each different angle. Just because you give a medication doesn't mean you have to document in the nurse's notes. There, you're documenting in the MAR, and that's sufficient, unless there is something that requires some kind of narrative. There's some complication with that medication. Documenting in the MAR is completely acceptable. Written summaries shall be completed at a minimum of every 60 days. This is a Medicare requirement. And the written summaries are basically the evaluations of the patients that on a minimum of every 60 days. I would recommend doing it more often, especially if there's change in condition, but you use your facility standards of what your standards are within your corporation. Documentation records patient's response to care, treatment, and services during the course of care, and the final results at discharge and transfer. So this is your narrative of how the patient is reacting towards the care and the treatment. If it is status quo and there is no change and they're reacting the same way, it is not necessary to document that on a regular basis. All documentation entries should be timed and dated, and this is very important that you time and date to be consistent. Documentations should contain several items. Assessments and observations are always documented. And depending on how your setup is, you may document an assessment or an observation on a specific form. You may document it in your nurse's notes. Just be consistent and make sure it's in the chart. It's important to document what actions you took in response to those assessments or observations. Not just that you saw them, but what did you do about them? Any symptoms the patient describes, you want to document, and you want to use the patient's own words when possible. Always try to quote the patient when it is applicable. Any unusual incidences that occur and the actions taken. If an individual falls, you want to ensure that you document the fall and what you did about the fall. Any incidences with a family. If you have an issue where a family is very despondent and upset about something, you may want to document that, but you're going to document what you did about that. If there is anything like that, you want to make sure you took the actions and you document that the family was upset about this and this is what you did. It goes a long way in litigation. It also goes a long way with customer service with the patient and the representative to show that you are taking an action, that you're not taking their complaints or concerns lightly. Administration of meds, treatments, and procedures, and the patient's responses to them, you're going to always document. As I indicated earlier, administration of medications can be just put in the MARS, but if it's a PRN medication and you need to document how they responded to that medication, you need to go a little further with your documentation. Always make sure you follow through with those. Any attempts to reach the physician or the personal representative needs to be made. You don't necessarily have to reach that physician. You can document that a message was left with the doctor's office and you're awaiting a response, or that you spoke to the doctor. But either way, you do need to make sure that you document that you made an attempt to communicate with the physician. Time and date of when you made that communication. You don't necessarily have to put the time because your note is dated as well, unless it was done prior or not at the same time. Medications, treatments, and procedures that were not administered and the reason they were not done. So if somebody doesn't receive a medication because they were ill and you couldn't give them the medicine, they were vomiting everything up, then you're just going to document that. And you're also going to document the attempt to the physician to inform him that the medication was not given. But that is the key, is that you're going to document the reason and what you did about it. Any kind of education or instruction, as well as the evaluation of learning provided to a patient and a personal representative, needs to be documented. If it's a new diabetic and you're teaching them how to give their own insulin shots, that needs to be documented. What also needs to be documented is the evaluation of their learning. You need to document how well they understood and how well they've done the procedure. So don't just document the education, document their evaluation of it as well. And any safety precautions that were taken to safeguard the patient. And a safety precaution sometimes may be not allowing a family member to see the patient if it's really upsetting them or something like that. That needs to be documented. But you need to document the reasons and what you are safeguarding against. The do's in documentation. Documentation should be timely at all costs. Entry should be timed and dated. And you should always sign your documentation, and that includes your professional designation, your RN, LVN, HHA. Whatever your designation is absolutely necessary to be included in the documentation. For those that are the electronic documenting that you do, you have an electronic signature that is recorded with your entry, so it is there. Just ensure that your professional designation is included as well. Use appropriate terminology and avoid slang and unofficial abbreviations always. Any abbreviations that you're using just because it is easier to write than to write out a diagnosis or cannot be used, especially any kind of abbreviations that you personally do. Your abbreviations should be those that are approved by your company. And avoid slang. Slang can be misinterpreted by many, and it's just not. It's very unprofessional and not a good place to use. Your writing, if you're charting by hand, it must be legible. And make sure your documentation is legible for anybody reading this, because it can, like I said, it can be used in the future, and lawsuits can occur 3 and 5 years ahead in the future, and everybody needs to be able to read what you wrote. Always include just the facts. There's no room for opinions in your documentation. Your opinions need to stay with yourself. You need to only document the facts as you see them. And do not scribble over or attempt to erase or white out any documentations. And this is for manual handwritten documents. You line through your error, you initial and date above the error to indicate that you are the one that lined through it. And then you proceed with your correction, sign and date your correction. But don't ever try to scribble over, white out, or erase any documentation. Do your own charting. Don't co-author charting that one person writes and you're co-authoring it. It becomes very muddled and uneasy to determine who thinks what. In the event that 2 individuals are witness something and you think it's important to put it in the chart, put 2 separate entries, each individually documenting in your own words just the facts. If a late entry is necessary, do not start a late entry by stating late entry. Instead, you chart the late entry and you note the date and the time that it occurred in your new entry. So if an event happened on 3/14 at 1500 and you failed to document it at the time, but the next day you went back and said, oh, you know what, I really need to make sure I put that in there. All you do is you date it. The time let's say it's 3:15 and it's 10 a.m. in the morning, and you're going to write on 3/14 at 1500 the patient complained of shoulder pain. If you put late entry in there, it's not wrong. It's just it's a red flag. So if you still want to document, don't not document, but just use that practice. And avoid shadow charting when you have written records. That is that you're writing the same thing time and time again. You've reviewed the last one you're writing, as opposed to reviewing the week's charting. If you're doing it, let's say it's a weekly charting, and you're doing a weekly summary, don't go back to the old summary and review that and say, oh, okay, nothing happened, so she's status quo, so I'm just going to repeat the same thing. Read the week's notes to see what happened, and then do the charting based on those notes. The same thing with your electronic records. Don't cut and paste. It's easy to cut and paste, but don't do it. Just go in. The electronic is a lot of check mark boxes. That's perfectly fine, but do it based on what has happened in the week. Don't go to the previous summary and follow that and do a cut. Do nots in documentation. Do not document a symptom without documenting what you did about it. And it could be something very mild of patient running a low-grade fever, and what did you do about it? You notified the physician, made the physician aware of that fever. And that might be all the doctor wanted you to do, but you're going to document that you did do something about it. Do not chart something someone else said to you unless you personally heard it from the source. That is, so-and-so said that this happened. Don't ever chart that. You're only going to chart the facts that you see or hear, and that's it. Don't leave sentences or thoughts unfinished. A lot of times somebody will be documenting and they'll be charting and they get pulled away and they stop in mid-sentence and that sentence is left open. Before you ever close your documentation, make sure you reread it and make sure you finished your thoughts, and to eliminate that open sentence. And don't make excuses. If a medication is not given because it was not available, don't document medication was unavailable, was not given. You might say medication not given, physician notified, med changed to such and such, or order given to administer med at such and such time. But don't make excuses like you didn't do something because it wasn't available. Do not chart staffing problems. Staffing conflicts do not need to be in the chart. This is a patient's autobiography. There is no reason any kind of staffing conflicts should be included in the chart. It has nothing to do with the patient. That it sticks with the corporate office and not within the patient chart. Avoid statements such as all needs are met. How can you ever be sure that you've met all the patient's needs? And as the example we typically give is how do you know you've met their sexual needs? You will not know that. So you do not ever state all needs met. It can set you up for failure in the future. Do not document frustrations with the patient. If you're frustrated with the patient, you need to keep it out of the chart. You can document if there's a conflict that occurred that affects patient care. You state the facts and you state what you did about it, but you don't document the frustrations with the patient. And don't mention incident reports in medical chart. An incident report is not part of an official medical chart. It is an internal document. The minute you document or make mention of an incident report in the medical chart, it becomes admissible in court. So anything that has to do with an incident report, a conversation you had with an attorney, anything like that does not belong in the chart, and it should not be there. But once you put it in there, you set the facility up to have to produce those documents, so they stay out. When an incident does occur, you do document the incident. You document what you did about it. You do not mention the incident reports. You do document that you notified the physician, the family, whomever it is. You do not You do not have to document that you notified the corporate office, because that too is an internal source, not part of the medical record. Avoid the use of abbreviation symbols and dose designations listed on the list of error-prone abbreviation symbols and dose designations published by the Institute of Safe Medication Practices. This list also includes the do-nots that JCAHO has published, and those are things like you don't record you don't use QOD or QD because they can be misread as one another, or the less than and greater than signs. You do not use those because they can be just construed as L's or other letters. You use less than or greater than. You write those words out. Also, magnesium sulfate and morphine. You don't use those medical symbols because those two can be misread and can cause some problems. So there is a listing of the Institute of Safe Medication Practices did create a list that is up to date, and it is a great tool to use to keep you from using those diagnoses and those abbreviations and so forth that can cause problems. And never alter a medical record. If something occurred and you think later down the road that it might, come to cause problems, don't ever alter anything. The medical record is the medical record. And that's why it's important to be very in tune to what you're putting in that medical record to begin with. Words to avoid. Do not use unprofessional or unflattering adjectives such as obstinate, drunk, obnoxious, bizarre. If a patient is uncooperative, then just chart the behavior objectively. Do not use derogatory words. You have to remember that who's going to read this chart. This chart's going to be read by a lot of people, and if you put derogatory words in there, unprofessional, unflattering, it makes you appear to be an unprofessional person in your profession, but it also almost can create a kind of animosity towards the patient and the caregiver. Speculation, conjuncture have no place in the medical chart. You write specifically the facts and what you did about them. Don't ever speculate or have any opinions on what you thought might have happened. Those should not ever be in the chart. Do not use terms with legal significance unless you're directly quoting the patient or the patient representative and you're going to show that you're directly quoting them. But don't use words like abuse, abusive, assault, battery, negligence, theft, anything like that could have a legal implication. You want to keep out of the chart. If an incident occurs, you document the incident, and then you document what you did about it, but you don't need to use those kinds of words. And avoid use of words such as by mistake, accidentally, somehow, unintentionally, miscalculate, anything that shows that you have made a mistake. If you do make a mistake, you chart it, but you chart what you did about it as well. Mistakes do happen. It's how you react to them that is going to determine how it is handled in the future. Avoid language implying patient's complaints are groundless. Don't say, the patient was complaining today, or the patient was complaining of pain today, but I don't think they had pain. Things like that, just don't do that. It also creates some kind of animosity with the patient and the caregiver, and can cause problems later down the road. Avoid imprecise descriptions such as large amount, soaked bed. Try to use measurable and definitive terms when possible. This isn't always possible. It's not. But you want to be as specific as you possibly can. So just keep that in mind when you're documenting. And do not use words that can be construed as derogatory. So if somebody's on a bariatric big boy bed, I realize that the bed is called a big boy bed. Replace that with bariatric bed. It just eliminates any kind of derogatory statement that somebody might feel is not appropriate. Another one that's very common is the use of the word diapers. Patients themselves use the diapers. Can you change my diaper? But you as a profession should continue to call them briefs. Eliminates that potential misunderstanding of derogatory. Things to consider when you are when you're documenting. You choose your words wisely. Use neutral words when documenting complaints or incidents. Don't use terms such as vicious, nasty, malicious. Just document the facts and keep with the facts. Avoid direct disagreements with other health professionals in the chart. If you don't agree with what the physician has done, don't document that in the chart. That's something that needs to be taken somewhere else. You can call the corporate office, that type of thing, but it does not belong in the resident chart. Always document patient complaints with non-bias, and just as important, document what you did about it. That is truly the most important thing that you should take out of here today, is that you need to document the facts. Don't take your emotion out of it, and document the facts and document what you did about them as well. And keep in mind that the patient, the representatives, attorneys, juries, at some point may see this medical chart. So what you document is a permanent record, and it will reflect on you as to how well you did. And one thing that your policy is to chart by exception. This is that you're going to chart the unusual incidences, the things that aren't done all the time. So instead of the patient is resting with eyes closed quietly, no signs of pain, that type of thing that is the same every time, doesn't necessarily need to be on there. You might want to mention it periodically, but not on a regular basis. But what you are going to chart is the patient had a little bit of a elevated temp, and inform the doctor of this, and we'll keep an eye on it, or that the patient has become more unstable when ambulating, notify the physician, and therapy was ordered, things like that. That you need to make sure that type of thing is always in there. And sometimes the littlest things that seem too insignificant to chart become huge issues later on, because it was a very small, minor, insignificant thing by itself, but in combination with other things became a major problem. So small things need to be documented just as well, and those are the things document by exception. And in conclusion, if it's the old adage, if it's not documented, it did not happen. That every day we preach that, because that is how the court system and the Medicare and Medi-Cal look at things. So make sure you document, but you document appropriately. And what is in the medical record can sometimes hurt you, but oftentimes what is not in the medical record has greater consequences. Like I mentioned, even significant things can blow up to be huge issues in further down. So you always want to make sure you are document by exception, document just the facts, keep the nastiness out of it, document facts, and document what you did about it. That truly is the key. So I hope this helps with your understanding a little bit more of documentation, and I look forward to talking with you again soon. Thanks.